Welcome to MHA 600. This is the introductory overview course for the Master of Healthcare Administration program. In this course we're going to cover a variety of topics. We won't go into a great deal of depth in anything, but we will have a lot of breadth here. The goal of this course is to give you a quick view of most aspects of the field. And then as we go through the program in the other courses, you will get more depth in each one of those areas and start to have a better, more thorough understanding as you progress through the program. This course will be reading based. You'll have a reading assignment. Interspersed in these reading assignments will be some of these audios. Once you've read the assignment, then you'll have a research-based paper to complete. Now what I want you to do there, read the course content first, read the associated book chapter that goes along with this course content, do some research on your own. Websites are fine, journals are fine. Try to stay away from mainstream media, newspapers, news, things like that. Those aren't really what we're going to call credible sources. And by all means, stay away from anything you hear on talk radio, left or right. It doesn't really matter. Most of those are biased to the point of ludicrousness. But anyway, once you've done all that, organize your thoughts, organize your ideas on paper, and then start writing. And I would expect that you will erase and rewrite many times as you go through each one of these papers. One thing I want you to do, though, I want you to be objective. When I read one of these papers, I should have no indication of your political affiliation at all. I want you to be completely objective. I want everything to be fact-based and well-researched. And if you have any questions about that or how to do that, feel free to email me or give me a call. This should be a fairly interesting course. I hope it is anyway. And you should get a lot of new information that you've not run into before here. As always, if you need help, send me an email, give me a call. Best of luck. One of the things I'd like for you to do as you get started in the course, begin to look at some of the international journals. There are probably as many credible journals printed outside the United States now as there are printed in the U.S. And as you look at those international journals, you'll start to get a little different perspective about healthcare, international healthcare, and U.S. healthcare. One of the first things that should strike you is that the U.S. spends more money per capita than does any other country in the world. But we generally fall out somewhere around number 37 in World Healthcare Organization rankings. And that's a huge discrepancy. We spend more than anyone else, but we fall out at number 37. And that's a pretty good indicator of our status right now. We're spending a lot of money, but we're not spending it very effectively. We're not spending it very efficiently. A lot of that money is going into administration. A lot of that money is being spent inefficiently. We've got a hodgepodge system in the United States. We've got a variety of insurance companies and managed care groups and PPOs and IPOs and all these various things, and it's not very well coordinated. So one of the things we're going to have to do as part of healthcare reform is find a way to coordinate all this healthcare spending so that we can really see where the money is going, so we can begin to get it under control. If you've been following the news, and it would be difficult not to, you should be familiar, at least superficially, with what President Obama has proposed. And if you watch the news in the past few days or few weeks, you should now be familiar with what presidential candidate Romney is proposing. And those two are kind of at opposite extremes on the spectrum. And the reality is that what's going to fix our system is probably not going to be either one of those. It's going to be something in between. But it's going to be something where we end up with some type of a national healthcare system, whether that be privately run, government run, quasi-governmental, something somewhere in between. But until we get a national system, there's really no way for us to get a firm grasp on healthcare spending and start to reel it in. You do need to be familiar with the politics of healthcare reform. That's not going to be our major focus here. Our major focus is going to be looking at things from the local level and maybe at times from the state level. But what we're primarily concerned about here is managing resources at the organizational level. That's going to be your primary concern. You don't have much control over what happens at the state level, perhaps. You don't have any control over what happens at the national level. But you will be the one who controls spending within your own organization. And that's where you're going to have your biggest impact. So your goal is going to be to find sources for revenue, maximize your sources of revenue, spend your money as effectively and as efficiently as you can so as to provide the highest quality and the most variety of services to your patient that you can afford to provide. And that will make you competitive in the marketplace. That will improve your catchment area. That will keep customers coming back. That will provide stability for your organization. As you go through your readings, you're going to come across the term socialized medicine. And if it's something written in the United States, it's probably going to have a negative connotation to it. It's kind of a term that is associated with bad or something we don't want here. The reality is we already have a very primitive form of socialized medicine in the United States. If you have insurance and you go to a hospital for a particular service, let's say you pay $1,000 for that service. Well, the service may only cost $300. The reason you pay $1,000 is because a typical U.S. hospital, anywhere between 30 and 50% of patients who walk through the door can't afford to pay for that service. So when you pay the $1,000, you're paying to cover yourself, and you're also paying to cover some of these other people who can't pay for themselves. So that is, in effect, a primitive form of socialized medicine. So we need to get comfortable with the fact that we're already doing that, and there's no way around that. Every country in the world that has any type of healthcare system has some mechanism in place where those who have insurance or those who have money pay at least a portion to offset those who don't have money. That's just a given. So we can't say that we don't want socialized medicine when we already have socialized medicine. What we can do, though, is look for a more efficient way to manage this redistribution of healthcare dollars. Right now it's done, like I said, in a very primitive way. We need some sort of system that does this more efficiently. If we had an efficient system, instead of paying $1,000 for that service, perhaps you'd only pay $800. So it would be more efficient than it is now. One of the biggest criticisms of the effectiveness of or the quality of the American U.S. healthcare system has been the fact that we don't focus much of our time or attention or money on preventive care. Our historical approach has been we wait until someone has a fully developed disease and then we jump on it and we start trying to find ways to treat it or cure it. In reality, that's the least effective and the most expensive way to manage a healthcare system. The best way to do it is to screen early and frequently, do preventive care such as vaccinations, and try to head off as much of those dread diseases as we possibly can. It's much cheaper to prevent a disease than it is to treat a disease. For example, a patient who has chronic obstructive pulmonary disease typically develops from many years of smoking, many years of self-abuse, Once a patient has COPD, they will be dependent upon the healthcare system for the rest of their life. They will develop frequent cases of pneumonia, frequent cases of bronchitis. They will be hospitalized frequently. End of life will probably involve hospice care. Again, another very expensive option. But if we'd spent just a fraction of that money that we spent trying to treat that patient early on to keep them from starting that smoking process, we could avoid that entire cost altogether. So it is imperative that we refocus some of our money on, or more of our money, on preventive care. Mississippi is a prime example in the fact that we are the fattest state in the country. Our obesity rate is somewhere around 34%. And we know without doubt that obesity is associated with an increased rate of diabetes, increased rate of stroke, increased rate of heart attacks, increased rate of peripheral vascular disease, and on and on and on. Obesity is a precursor to many of these dread diseases that cost us so many dollars. So what we could do is spend more of our money trying to educate people early in life, trying to teach these people how to eat more effectively and more nutritionally, teach these people how to exercise more so as to avoid the obesity in the first place. And that way we would save all that money that we're spending on heart disease and strokes and diabetes, and save a ton of money in the process. In fact, we have had some very creative programs in Mississippi just to do exactly that. Blue Cross Blue Shield several years ago started charging an insurance premium for anyone who smoked. At the same time, they offered a smoking cessation program free of charge. And they saw a dramatic decrease in the incidence of smoking among their employees. Not just because of the financial incentive, but because of the education that went along with it. They're starting to do something similar to that now with obese patients. If your body mass index is above a certain level, you have to pay essentially a premium on your insurance because you are a much higher risk patient for filing an insurance claim. Again, by the same token, they're doing education along with those higher insurance payments to educate people why they're charging them more for insurance, and hopefully that will help them get their BMI down, become healthier people, and become less of a drain on the healthcare system. One of the frustrations that those involved in public health often run into is the fact that most Americans don't see the implications of public health. They have this attitude that, if I want to ride on the roof of my car down the highway at 60 miles an hour, then that should be my prerogative. And in reality, those kinds of behaviors have a significant impact on those of us who don't engage in those behaviors. The best known example is helmet use for motorcycle riders. Several states have done research before and after helmet laws were implemented, and the cost of care for those who are involved in motorcycle crashes who don't wear a helmet is significantly higher than it is for those who do wear a helmet. So whereas we might be inclined to say, if I ride a motorcycle, I don't want anyone telling me whether I have to wear a helmet or not, when you look at it from this other perspective where it does impact everyone when they don't wear the helmet, all of a sudden it becomes more of a public health issue than one that people feel like they might have a right to weigh in on. The thing holds true for seatbelt use. It holds true for smoking. It holds true for obesity, and a whole host of other things that we might list. But anyone who engages in a risky health behavior is actually a burden to society. Those of us who don't engage in those risky behaviors pay for those who do. The uninsured motorcycle rider who has a closed head injury, which costs $400,000. Those of us who have insurance bear that cost. So those of us who have insurance have a vested interest in seeing that the guy who rides a motorcycle wears a helmet, or seeing that we do something to reduce the incidence of smoking, or we do something to reduce the incidence of obesity, because it does hit us where it hurts the worst, in our wallet. We pay for it. This is another costly area in healthcare that's just over the past 10 years begun to be fully appreciated. We now know that upwards of 20% of all patients admitted to a hospital receive a wrong drug or a wrong dose. We know that 17% of patients who are admitted to a healthcare facility receive an inappropriate treatment. Now, we don't know the exact cost of those mistakes, but we know it is significant. So we've got to do something to get those kinds of problems under control. Those are problems where we're just throwing money out the window, basically. These are things like somebody comes in for one condition, gets treated for another condition. Or someone comes in who has a problem that requires a treatment by a particular medication, but a mistake is made and they get another medication, and perhaps that wrong medication causes additional problems for which they have to receive health care treatment. And the problem just it tends to snowball. Also, those types of errors result in all types of malpractice claims, lawsuits, findings against hospitals, and all those types of things that indirectly cause us to have to pay more for health care. You know, if a hospital has to pay out a $100 million suit, their insurance company will pick up part of that. But a lot of that is borne by the hospital in the form of insurance premiums. And those insurance premiums, the cost of those premiums has to be passed on to us as patients. So we bear that cost as well. So anything we can do to reduce the incidence of mistakes in hospitals, again, will improve the status of our wallet. For this first assignment, what I would like for you to do is do a little historical research. Go back, start say around the 1960s, and then move forward from there and talk about the status of healthcare in the 1960s and what's happened since then. What I want you to do is I want you to develop a working basis or a good strong historical understanding of what we have and where it came from. You can't really understand completely what's going on right now without understanding what we've had and how it's evolved over the last 40 to 50 years. Now, as you do this, I want you to stay away from the Accountable Care Act. I want you to stay away from what Romney is proposing. We'll talk about that later on. But right now, I want you to get us up through about 2010 and try to develop a pretty good understanding of the history of modern healthcare in the United States. I think you'll find that to be some enlightening research.